We're going to start tonight. My name is Kirschenbaum. I am the chairman of Orthopedics at Bronze Care Health System, but I am also the editor of the Journal of Orthopedic Experience and Innovation, otherwise known as Joey. As we like to say, Wednesday night in orthopedics is Joey night. And tonight we have a great topic on our open mic session, total knee arthroplasty in a has cementless become a new standard of care or cementless knees? Do we do them or do we let the bone decide? There's a number of titles to this, and we're going to, first of all, introduce our panel. They'll introduce themselves. Rob, Sershon, you want to start first?
Yeah, sounds good. You guys, Bob Sershon, Anderson Clinic, been there since, well, I guess I was a fellow there in 2018. So we can count from then and still going strong. So thanks for having me.
Excellent, excellent. Scott Mabry?
It's Scott Mabry. I'm in Birmingham, Alabama at UAB. Did my fellowship at WashU and been down here for the last 4 to 5 years.
Excellent. And Charles Taunt?
Hi, Charles Taunt. I'm in Lansing, Michigan. I trained with Henry Finn at the University of Chicago, and I've been teaching residents at Michigan State University for the past 20 plus years.
Excellent. Excellent. So we're going to start off with laying down the groundwork a little bit. For many decades, cemented fixation and knee replacement was the dominant force, was the dominant way to do it. There were a number of attempts to do cementless over quite a number of decades. But it looks like things might have changed. Certainly in the last 10 years, there has been a certain acceleration, maybe a little bit before that. I'll start with Charles. What do you think? What do you think has kind of happened? Was there has been a shift? If or tell me about the shift in your practice, if there has been a shift.
Yeah, there's definitely been a shift. I think that what we saw historically from the 90s through, I don't know, 2015, and I would say that from probably 2002 to 2015, there were really very few and not very popular cementless implants. But the thing we saw, right, was that the tibia failed. In the 90s, there were lots of attempts at cementless knee fixation, and the femoral side usually worked, but the tibial side didn't. And even there were hybrid knees where you'd cement the tibia and press fit the femur, and then people said, well, what's the advantage of that? What the cost, time, and whatever. There isn't really a savings there, and so we went with cemented knees, which had a great track record, and there's absolutely nothing wrong with cement. I think more recent tibial component designs with better metallurgy and better initial fixation of the tibial component has shown us success on the tibial side, and then the adoption of cementless knees has sort of followed from there.
Bob, what are your thoughts about this? I mean, you come from cementless land, the Anderson Clinic. I mean, they were uncementing since the 1600s at the Anderson Clinic. So tell
That's
me,
right.
tell me about it.
Yeah, I mean, for me, my career's not even been 10 years, right? So when I first started, cementless was already taken off. The guys at the clinic were already probably about 25-30% cementless when I was a fellow. I mean, it wasn't crazy. It wasn't like it is now where we're putting in cementless whenever we could. Um, why the big change? I mean, I think Taunt hit on a bunch of it, right? I mean, the fixation's better, the materials are better. Um, we have better interference fit early on. Uh, Quite frankly, I think a lot of the instrumentation's better. I think robotics had a huge role in that. It definitely did for me early on in practice, kind of giving me more confidence in the cuts versus, just being by myself manual early on. Now it's the opposite, but I think that all of those factors, over the past 10 years, improvement of technology, kind of learning from past mistakes,
Mhm.
having implants, show early promising results, gave people a green light to start doing this more frequently. And it's also a conversation with the patient. We could talk about this later too, but it's an easy conversation now for me to have with a patient of, hey, you maybe got a 0.5% chance the first year of something failing, not getting fixation, but it really starts to decline after that. In terms of cementless fixation, we think that once it fixes and it's ingrown, that's it, right? You'll have plastic wear, but we don't worry about loosening down the road.
Right.
Um, Now that's still to be determined, right? We don't know if they're going to get massive osteolysis and there's going to be some problems 10, 15, 20 years down the road where things come loose, but that's our best guess right now. So that's my thought on it.
Scott, you want to add something to this?
Yeah, I mean, I t certainly agree with a lot of those points. And I think that the keel design, especially on the tibia, has improved with a lot of the different options that are out there. So I think that initial interference fit certainly leads itself to less that micro instability as you get the ingrowth with the press fit implants. So that plus the porous coating, and I certainly agree that the more precise the cuts are, the better chance you're going to have for a robust interface.
Excellent. We have kind of a critical mass of people. I want to take a little poll here. I'm going to launch the first question on the poll here. I think there we go. What percentage of your current TKA practice is cementless? Let's see how people could answer that. We'll keep it going until I see a critical mass stopping. Oh, that looks good right now. So you guys can see this, right? We have 38% less than 10%, which is quite a difference from the faculty, and about 20% greater than 75%, which I think is quite interesting to see. A number of people are in the middle. Um, they're the people who can't decide in a way. But 38% are less than 10% are what percentage is cementless? 37% less than 10%. Well, we're gonna talk a bit about that. All right. I'm gonna end the poll right now. So I'm gonna share the results. There we go. Okay. And I'll stop sharing now. Okay. Let's get out of that. Two people in the waiting room. So let me ask, Scott, we got 38% of people who are cementing. What's up with that?
Yeah, I think there's a lot of factors involved. Certainly implant choice is an important factor. Not all companies offer a cementless option or a good cementless option. And so I think it's very reasonable if you
Sorry,
prefer a
I'm on a work
bearing
call.
design
That's okay. I'll talk in a bit.
or at least the implant that doesn't offer a cementless option. And I think there's no problem with that. And also, if it's been your practice to cement and you've had great results and don't feel like you need to change, I don't think it's necessary. But for us that do like the biologic fixation, do like the cementless options, do like the efficiency that it brings, I think that's a good option. But I certainly wouldn't want to try to convince someone that they should stop doing what's been tried and true for them or change implants when they have something that works very well in their hands.
Right. Bob, what do you think about the people when you lecture, when you go around and people ask you, let's say you meet one of these people at 38% and they say, I've just been using cement and it's been fine, but tell me about your decision making on cementless. What kind of technology are you using that makes that convinces me to go cementless?
Yeah, I mean, the decision for me to do cementless is more for long-term fixation, right?
Yeah.
I kind of alluded to it earlier, but uh, I'm more willing to take the risk up front, right? I would rather have that, um, make sure I have a little bit more precise cuts potentially than with a cemented construct. So that's kind of where my thought process comes in is I'm going for long-term fixation. Now you could argue people in your 80s, what are you doing, Bob? Why are you breastfeeding those people? If the bone quality is good, that's just my flow. It's what I do. I think from an efficiency standpoint, you could argue that it's a bit more efficient, but the alternative argument, and this is what DeCook and I talk about. He would say, hey, you're working with fellows, you got trainees. If you're going to let them go, cement's a little bit more forgiving, right? You don't need the absolute perfect cut, and that's a good rationale as well. It's definitely more forgiving, and from the cement side, you can do cement balancing too, right? And we could all pretend that we don't do it, but I mean, cement can balance a knee pretty well for you. You got a couple millimeters difference in a gap, so it's definitely more forgiving than cementless. I think cementless just requires a little bit more of technical mastery. I don't really have a better way to say it. I mean,
Yeah, no,
there's
that's
really not as much room for error, and I think that's why early on in my career, I just came out of fellowship. I mean, we were trained well, but I just didn't have the confidence that I have now that I can make perfect cuts almost every time. So that's where I would tell someone who's been thinking about, cemented versus cementless, if they're just not doing it because they're worried about fixation and they're worried about longevity. I mean, I think the data at this point would tell you, hey, you got less than a 0.5% chance even in the morbidly obese. I mean, we just published a paper showing it's like a 0.3%. I should look at the paper, but it's 0.3% through 5 years failure rate of the tibial tray and
wow.
morbidly obese. I mean, you're not going to beat that. And as time goes on, it's that tibia is not coming loose. So the cemented, that's going to come loose over time. So those are all good arguments towards, why maybe they should go over to it.
Yeah. Scott, what system are you using now? And what do you think are the advantages of that system? Because you're over 80% cementless.
Yeah. I use the Zimmer Biomet Persona with an osteotomy tibia. I think a lot of the benefits there, like I said, I mentioned the keel. That was one of the big things that pushed me to start using that, and I thought I had a great initial fixation.
Okay.
A lot of the surgeries I do, I use with the ROSA robot, so I think that offers an advantage of a little bit more precise bony cuts, especially with someone that's relatively newer in practice. But even manually, I'm still doing cementless knees and feel very confident there. I think the medial congruent poly is also really an effective part of that implant system. And so I think when you tie all three of those together, it's got pretty much a well-balanced, portfolio from what I'm looking for in a total knee.
Were you using the same implant when you were cementing a little bit earlier?
Yes, so I was using that. I was using a few other companies as well, just trying to get a feel for what was best in my hand. And I had no troubles with the cemented version. I felt very strongly that cementless was the direction my practice was going to go. My fellowship was heavy in cementless knees, and so that was really what drove me to use it in my own practice.
Charles, what do you think about implant choice when it relates to cementless fixation in total knees?
Certainly, the core coating or the bio-ingrowth surface is important. I think like that Scott mentioned the osteotized surface of like a 3D printed rougher, more bone-friendly surface versus on the tibia, especially where the sort of historical challenge on early fixation has been and getting earlier like ingrowth there. That is it probably matters. It probably matters more than it does on the femoral side. I mean, I think there's a bunch of companies now that have like good press fit components for knees that have are successful in the cementless realm. There's probably a few that are better than others. Again, the press fit on the keel some initial rotational stability. Even beyond
Yep.
that, the little pegs that are in the tibia. I mean, even going way back to the that which is a different material and a different processing standpoint, but the old 4 peg for mostly like monoblock
Yeah, I remember
next
that. Yeah.
gen press fit tibia with trabecular metal. I mean that component worked really well because it was initially stable, and the biology of bone growth into that material is superior. So it worked on the tibia well. Historically, I think that the new design has some workflow advantages, and maybe even more stable initially. So I
You're
think
talking
it's
about the
that.
RCOTI.
Yeah, that one is probably superior to the old one, but versus like a plasma spray on chrome cobalt, going way back to like an LCS press fit tibia from 2002. What we have today is a different animal. I mean, it looks the same, but it doesn't really work the same.
Yep. Marty Nichols, you have a question for us. You want to unmute your mic and your video and lay it on us.
Yeah, in the 90s and the 2000s, when we tried it with the LCS and some of those, one of the concerns of the early tibial failure was blamed on early ambulation. We were keeping those patients for 6, 8 days in the hospital. And now the new pathway is pushing patients out the door as fast as they can. Are you guys post-op in your press fit knees differently than you would post-op a cemented total knee?
Yeah, why don't you, we'll go in or Scott, you want to take that? And then we'll go
Yeah.
to Bob and then Charles.
That's a great question. I don't change anything in the first 6 weeks with my post-op patients. I feel like that initial stability is great. I will caution golfers at 6 weeks to still be easy and gentle as they're easing into the golf swing. I think someone coming into a full swing could put a lot of torque on the knee. But that's about the only caution that I have that's different from my cemented knees.
Excellent. Bob?
I don't do anything different, but I don't have a very aggressive early protocol. I mean, their first 10 days are on their butt, elevating and icing for 40 minutes an hour. Um, so that's, I think that in and of itself, not being hell-bent on get to PT, get cranking on the knee right away, get the knee nice and swollen, walk 10,000 steps a week. I don't do any of that. So I think the protocols in and of itself, kind of take care of a lot of that early
Sure.
concern.
Sure. I mean, we've had Andy Wickline on here before talking about uh his tsunami knee protocol. And a lot of people have done that for years, even before Andy, and but he certainly popularized it. Charles, your protocols changed or
Yeah,
about the same?
no change. Marty and the team, full weight bearing, quiet knee protocol, but I see them at 6 weeks and get an X-ray, and if their X-ray looks good at 6 weeks, I'll let them rip at the golf course and like let them go. Usually, um, folks don't really feel up to too much more aggressive activity than that in 6 weeks after a knee replacement. So I think you get some element of a self-inflicted window of slowed down activity, and we try to hold people back on a few more vigorous activities, but early on full weight bearing, advance off a walker when comfortable, no limits on cementless knee.
All right, so we're gonna do another poll with sort of related to some of this. I'm gonna launch this right now. Approximately what percentage of your cementless knees are performed in patients over 60? Over 60. Okay, we're looking at the over 60 group. How many are you doing cementless in over 60? And faculty could vote in as well. I can't because I created the poll. Okay, so we'll keep it going. Okay. Um, all right. It's looking about 20 is like my minimum. Yeah, we hit 20. It's good. So we'll end this poll. Um, so it looks like 10% are in over 75%. We still got our base here, our 35% base of cementing everybody, but we kind of have quite a bit of people, 30% in the 51 to 75%. Um, this is what the share. You can see this, right? You can see what I'm looking at, right? 75%, 10%, 50 to 75, 30%. So above 50%, you have about 55% of people. So that's very interesting. Let's talk a little bit about this. All right. Let's talk about these indications, patient selection indications. And Charles, I'll start with you. Let's talk about male versus female first. Any concerns, the decision making in the cement versus cementless? If you're a cementless guy, which you seem to be, are you pushed a little bit with a woman over 60?
Yeah, so uh, uh, women over 60, I mean, I think it really just depends on your intraoperative assessment of the bone quality. The bone quality needs to be good enough that you're confident in your initial fixation. I mean, just like a hip stem, right? If the thing is going to rock, if it's going to micro move, then the bone isn't good enough to support it, then it's not going to ingrow appropriately. And so you have to be confident with that. And I think there is a little bit of a learning curve for that, although I think there are some tips. The one that I'm very cautious about is very thin women in their mid 70s and up, the patients with established documented osteoporosis or metabolic bone disease I'm going to cement them. I think those are the hardest, like osteoporosis patients, to get better. And like we have a bone health clinic in our practice, and they're oftentimes sort of malnourished or undernourished. And you have to, I mean, I'm choosing to be careful of those patients. On the contrary, right? Like sometimes these real obese women with, in more advanced age, sometimes their bone is incredibly hard, and their nutrition, I guess, is better in a way, and their bone is seeing more force. But the 78-year-old lady who looks fit, but who might be eating, toast and tea for breakfast, I think you have to take caution on their bone quality. So that's the one where I'm very careful. And my threshold to just convert to cementing them is low.
Sure. And my understanding is that the all the guides and the jigs and everything's the same on cemented or cementless on the system you use, right? So you don't have to change.
Yeah, with the Persona system, really with the triathlon system, you can pretty seamlessly move from one to the other.
Right, so you can make the decision on the fly. So we have male versus female, age, obesity, bone quality. Scott, what's your feeling?
Yeah, I would say in patients under 80, my mindset is cementless first and then check the bone quality and be convinced if I need to cement. I do a test of the tibia more than anything where I take a bovie. If it plunges into the bone, that's going to be cemented every time. And also when I put a lamina spreader to look in the back of the knee, if it indents the tibia at all, or even if the cuts are imprecise or I'm worried about that, then I will go ahead and cement. So it really is an intraoperative assessment. Patients over 80, I'm thinking cemented first, and I have to be convinced pretty unequivocally the other way to press fit those. And I mean, I've been surprised. I had an 84-year-old today that the bone quality was incredible, and I ended up press fitting her.
Yep, Bob. Um, I know you do a little over 90%, but there are some people who use cement, so what are those? How does the bone decide on those for you?
It has to be embarrassingly soft. Like I
Okay.
have to be able to basically push my thumb through it. When that happens, they're getting cement in my hands. And I think, one of the reasons I've gotten so aggressive about it, I mean, we just looked at our data over the past 4 years for a study. We're looking at cementless fixation with kinematic total knee alignment, unrestricted. And we had one tibial failure due to aseptic loosening, but it wasn't an 83-year-old female, right? Now she swears PT did it. They flexed her too much. That didn't happen. I mean, she subsided and just started having pain after that, probably. But yeah, I think that, and we could touch on this now or later, but implant positioning is really important. The fill of the tibia, having a nice asymmetric tibial base plate, in my opinion, really helps fill, get some nice cortical contact everywhere. I have, if I'm between sizes, I'm okay with, a millimeter of overhang. I'm not going nuts about that. I'd rather get cortical support all the way around the implant. And if you can get that, the chances of the implant subsiding are, I mean, they're low. They're low, right? We have 1 out of 800. It's not impossible, and that doesn't mean there aren't some stragglers hanging around that maybe have some fibrous stable base plates that we'll find out in a year or two. But if you get full cortical coverage of that base plate, I think you're in good shape, almost regardless of bone quality. It's just that in these 80-year-olds that are possibly osteoporotic or have soft bone, I just don't. The reason I do cementless fixation for longevity of the implant, I don't think that is a good rationale anymore. They're in their 80s, even if they're super healthy and make it to 100. Cementing someone in their 80s is probably gonna take them the whole way. So if they have really soft bone, that's about the 10% that I will cement.
So we got a question from Mark Sanders from Texas. You got a question, Mark?
Yeah. When we evaluate a person for their general health, as we may get them ready for a total knee, if they've had a history of malignancy or they have type 2 diabetes, maybe I could get them to get the A1C down, but they still have diabetes. And should that go into the decision making of whether we go cement or uncemented? Because some of these people are inherently sick, and well, they may have good bone. They may appear to have good bone, but maybe that doesn't have enough oomph to grow in, or for the native tibia, for example, to embrace this new plateau. No, this new tibial plateau.
All right, let's start with Scott, then we'll go to Charles and then to Bob.
Okay.
I
Scott?
think it's a good point you bring up. I still ultimately rely on the intraoperative assessment. Now, I have been burned in the last year by someone that had aseptic loosening of a hip from another surgeon, and I didn't really account for that. And her tibia has loosened up within a year of putting it in. So there may be an underlying metabolic bone issue that I didn't pick up on her. Intraoperatively, her cortices were great. Her cancellous bone was strong. So that is one case there. I think it's a consideration. But then again, I ultimately rely on that intraoperative assessment. This is a one-off so far.
Yep, Charles?
I would say that I don't think a patient with reasonably well-controlled diabetes, that we have any real data to support that their bone metabolically is different than another patient. And if their diabetes is poorly controlled, they shouldn't have surgery until their diabetes is better controlled. But I have a bunch I will tell you that I will cement. If they have cancer in their bone, although it's very rarely in the metastatic cancer, although it's very rarely in the distal femur or the proximal tibia, I'm going to cement them, because sometimes they're on medication that I don't really understand how it affects their bone metabolism. If someone has prostate cancer that's on one of these chronic treatments, or metastatic breast cancer, so I'm not going to count on the bone to ingrow in them. Patients with like renal failure, either like the stage whatever, late stage 3 and certainly stage 4 kidney disease, anybody who's on like dialysis, anybody who's had a transplant, I seem to get these patients with. Lately, I had a couple with pancreas and kidney, and sometimes both pancreas and kidney transplants. Like they're on chronic steroids, anti-rejection medicines. How that affects their bone metabolism, I have no idea. I'm cementing them. So I think your point is well taken in certain patients who are medically complicated. That in my mind, I'm just not going to count on their bone biology, so I'm going to cement those patients.
Okay, Bob.
Not very common. I mean,
Oh, I'm sorry. I'm sorry, Charles.
Yeah, Charles nailed it. Nothing to add to that. That was perfect.
Yep. So you agree with with the cancer and
Yeah, I mean, a poor host, I mean, don't rely on their body to
yeah.
do the job. Yeah, I think that's a good message.
Yep. Let's pivot a little bit into a topic that gets brought up quite frequently when talking about this, and that's efficiency in the OR. Um, Time savings, OR efficiency, hospital efficiency, ASC, patient recovery. Those are the big topics in the efficiency world. Whether you're a 12 by 12 fanatic or a 17 by 11 fanatic or a 2 by 2 person. Bob, what's your feeling about in your ORs, the efficiency that Cementless gives you?
I mean, for me, it saves me probably 5 minutes a case. That's about it. Because when I cement, I'm still just popping in the poly, putting the knee in extension and letting it
I
hard
mean,
there.
how do you pull both of them?
Oh, hold on a
So,
second. Got to mute
um,
everybody.
yeah, so it probably saves me about 5 minutes. But again, if I didn't have to be so pathologic about the cuts, and we could be a little bit more forgiving with the balancing, it could be potentially time neutral. But it's just nice to have a system that, and again, sure, I use Persona, I consult for Zimmer, et cetera, but it is nice to have that system where it's okay, whatever, cementless, whatever you want to feel at that time, you can go back and forth. So I don't really think about honestly, as crazy as it is, the efficiency of it anymore. It's just my preferred pathway at this point.
Mm-hmm. Okay. Charles, have you noticed efficiency across the board with not only with the cementless, but also with the single type broaching, single instrumentation, you know, tell me about efficiency of the system.
Yeah, I mean, I don't think there's any question that it's more efficient. Whether it's today we did 6 knees today, and we cemented 2 of them. One because the other one was cemented on the contralateral side, and that's another one of my I don't mess with success. If the patient's happy with their cemented knee, I just do the same thing. The other one, the bone was crummy, and so we cemented 4 out of, and it feels like forever when we're leaving the tourniquet up longer and waiting for once you get into the flow of cementless, the cement seems like forever. I did a little quick math. If you had a 30-year career and you did 250 total knees a year over 30 years, and your average cement hardening time was 8 minutes, that if you worked a 50-hour work week, that just the cement hardening time in your 30-year career would be 20 full weeks of work. Almost half a year's time of your career, you stood there waiting for cement to harden. Wow. So if you can get that out of there, the other thing that's nice is when you get that X-ray and there's cement off the tibia usually that's snuck up under and you didn't know it was there and you didn't get it out and you're like, oh, it's totally fine, but it looks bad. That never happens in a cementless knee. The parts are the parts, and there isn't cement. There's a little ooze of cement on 1 out of 50 or 1 out of 100. I'll get this little bit of cement. It's back in the notch you see on the lateral, behind the tibia that came out once you put it all together. You couldn't see it. So that's kind of nice too from an aesthetic standpoint. Functionally, I don't really think it matters, but there is some time savings there for sure.
Sure. Scott, for you, the whole workflow?
Yeah, I think the cementless workflow, the real point of efficiency I found is that when I trial a cementless knee, I know that's the poly that I'm putting in. So I'm not going to come back after waiting on the cement and retrialing, maybe a little bit more laxity. But also just from my workflow too, I like to go tibial base plate, polyethylene, and then thermal component. So when I do a cementless knee, I'm able to do that without the concerns that there's extruded cement that I don't see, or that my gap has loosened up a little bit as the cement is compressed against the bone. I'd say the one downside of being cementless first with the bale to cemented, I lose time waiting on the cement to be opened. I think that's one kind of factor when you play into this, but really the efficiency, it was the driver early on when I was using the robot with cementless, but now I don't really think about it as much. If the case calls for cemented, it's not a big deal to me. I think it's the right thing for the patient. If I was doing only cemented knees, I didn't think I would be wasting a lot of time.
Interesting. When I first trained, the wars were cemented or cementless hips. And on one side, you had Charlie Yang, of course, and you had Bill Harris on the other side. The question right now, for a while was when cementless stems were doing very well, what were the barriers to people changing over? So I want you guys to kind of think about hypothesizing. What do you think is a barrier for somebody who uses cement now, but who's listening to you guys? I mean, Bob's at 91% and waiting until the bone disintegrates in front of his eyes before he uses cement, and just a little exaggeration. And each of you are over 80, for sure. What do you think are the barriers for, and would love to hear from some of the people in the audience who are cemented people and why they're using it. So please put those questions in there. But we'll start with Bob. What do you think are some of the barriers for some of these 38% of the people who are using 90% cement? What's holding them back now? We got a great system.
I mean, one might be what held me back early on was just guaranteeing your cuts were perfect. Um, that just, now I could say it. Back then I would have never admitted it, but it's always in the back of my head. So that was one. Two, it's a hard discussion to have with someone early on within 6 months of a surgery. Hey, your part didn't fix to your body. We got to go back in. You just, maybe I shouldn't say never, but I mean, you almost never would have to have that conversation with a cemented knee. So, to get 10 years down the road, it's a failure. Yeah, maybe someone's not so upset about that. Maybe they are, but that's a long time down the road to have a well-functioning knee that, maybe something eventually goes wrong. So from a optics standpoint, it is higher risk. I think people earlier in practice, you can't have those early failures. Not that we want them, but I'm going to be practicing for 20 years. I don't want to be revising my patients at the end of my career because cement's failing. So that's probably the biggest barrier. It's just people worried that early fixation is going to fail, and now we have a plethora of data saying that's not a real concern in the vast majority of patients that use cementless fixation on.
Yep. Charles, what do you think of the barriers for some people?
It's going to be cost depending on their health system or their ASC or whatever. There probably is a net implant cost on a cementless knee versus a cemented one after you account for the cement and the disposables of, I don't know what the average is across the country, but I'm going to fathom a guess of probably like $600 or $700 on the implant. So there might be some pressure to not do it then, to not experiment with again, I think Scott mentioned, if the implant system that they've had the most success with doesn't currently have a good uncemented option, I suspect almost all of them are going to be moving into the realm of having a cementless option and doing a good job on design, but that takes time. And I mean, there's always people that just say, this is the way I've always done it. This is the way I like it. It works well for me. And I mean, I think when you're talking about, 98.2 in one recent study cemented versus 99.5%, 5-year survivorship, I don't think you can criticize the surgeon who's using the technique that's 98.2% if that's what they're comfortable with and that's what they've always done. So I mean, I guess maybe a better comment from me, or it isn't exactly an answer to your question, would be like if somebody wants to start doing some cementless knees, like where should they start? So my answer would probably be in a metabolically healthy, man, male 60 and under that has that really hard bone. I mean, those Bob talked a little bit about. I've had a few of those, kind of fail at around a year, 14, 18 months, where cemented ones now I'm talking about in my career, the bone is just so hard. You're trying to get cement penetration into the bone and you're drilling holes and whatever. And for whatever reason, like they don't work. And it's not common, but it happens. And most people, you do enough cemented knees, you're gonna see some failures on the tibia in obese patients. You're gonna see some failures on the femur in people who have really hard bone. And so those are where I would tell people to start cementless, because I think cementless might be superior in those patients. And then move your comfort level and follow your patients, follow your X-rays, and kind of slowly see what you think from there.
Yeah, Scott, some comments on barriers and maybe a little bit what Charles just talked about, which I think is critical.
Yeah. I think the biggest barrier is just a very common barrier in all of orthopedics. It's, this is the way I've done it. It's very successful in my hands. Why do I need to change? And I think, successful change needs to come organically from the surgeon. I don't think you should be told that you're doing it wrong. I think, there should be some curiosity, or there should be this willingness to go, and try this new technique. And if you don't have that, I don't think it's for everybody. And I think finding that well-indicated patient, my early press fit patients in my own practice were the young, healthy males with great bone quality, and I expanded from there. And I think the safe expansion into your practice is probably the best way to build that confidence with that technique.
Yeah, and also I think Charles brought up the point that there are companies that have been in the cementless tibia business successfully for longer than others. And probably if I was choosing to switch, I would consider a company with a little bit longer follow-up in that area and not be the first on the block. What do you think of that, Scott?
Yeah, I certainly agree. And, if you're going out on a limb with a new technique, you would want to go with a company that's got somewhat of a proven track record and they're improving on previous technology and not rushing to market to keep up with the Joneses, so to speak.
Right. Absolutely. We have a question from Brian Sang. Brian, you want to unmute yourself and ask your question if you can? No, wait a
Yeah,
second.
thanks. I was just wondering if you find your patients have more post-op pain with cementless knees.
All right, let's go around the horn here. Bob?
We're doing an RCT with ZB right now, looking at cemented versus cementless. Getting 2-year data. I think they just submitted an abstract, but there was no difference early on. It's industry funded, whatever you want to say about that, but the data is the data. It's objectively, prospectively collected, randomized data. So really well done study, multi-institution. One of my partners, Kevin Fricka, he's a big cementless knee guy as well. He says they have more pain post-op. I mean, and it would make sense. I'm not going to argue against that. I do so few cemented, I can't tell you. But I do kinematic, KA knees that have a little bit of a faster recovery anyhow. I think the data, I could say that, pretty easily now with all the data available. So cement stops the bone bleeding. And so, if you don't have as much of a hematoma post-op from cement, maybe you have less pain. There's going to be some micromotion. I mean, it's not zero. And so that probably, would contribute to a little bit more pain. I just think that clinically, we either don't have proms that are sensitive enough, um, or, techniques are so varied between surgeons that, someone that's doing more of a personalized alignment versus a mechanical alignment surgeon, you're not seeing the difference because the personalized alignment may have a little bit of faster recovery, but they're hindered by the cementless technique where the mechanical guy may have a little bit of a rougher early recovery, but they're cementing, so they don't have as much of a hematoma. So I think there's a lot of confounding there, unfortunately. In my practice, I haven't seen any. In the study we just did, we didn't see any.
Okay. Charles, you notice a difference?
Uh, Totally anecdotally, it seems like uh, real active patients, maybe who are more active than we tell them to be in the first few weeks post-op, have a little bit more like shin pain. Then I saw that, especially when I started doing more press fit. I was moving to way higher rates of cementless versus cemented. We observed that in the like 2 to 4 week post-op period. Um, it seems like even the more I do that concern has gone away, but I think I'm doing a better job of trying to keep their knees quiet a little bit longer, and so maybe that just hasn't come up. But I would say I think there is some anecdotal experience with a little more like you said, kind of shin pain in that period of time.
Scott, your feelings about this?
I'd say with my feelings, with our current pain protocols and the kind of the different PT protocols that are evolving, I'm not seeing much in the way of a difference in pain at all between cemented and cementless. I don't know if that's a factor of how good our pain protocols are becoming and the medications that we're starting to use, or if it's just that there is no difference between the two. So in my own practice, I haven't seen the difference.
That's excellent. I have one last poll question. It talks a little bit, it's going to be talking about the future a little bit. Um, will cementless fixation represent the majority of your primary TKA within the next 5 years? Yes, no, unsure. All right, we getting there. Well, we got a pretty big unsure kind of group. Very very unlikely for an orthopedic group to be unsure. Yeah. Uh, but we'll discuss that as well in a little while. Certainly, 53% are now saying a majority of their knees will be cementless over the next 5 years. 11% no, holding strong on the cement, and 37% a little unsure. Maybe they're waiting on some more long-term data. Maybe they're waiting for the joint replacement they're using to be as successful as the one you guys are using. So we'll take that. Here are the final results of that survey. 19 people answered, 53, 11, and 37%. It's pretty cool. Pretty cool. Um, I'm going to ask one last question because this is, as we'd like to say, and Mari Nichols knows this, this is the fastest hour in orthopedics. Um, and I, what do you think, what technologies or evidence will drive further adoption? What techniques or evidence will drive further adoption? And I'd like to start with Scott, if that's okay. What technologies or evidence will drive further adoption?
Yeah, I think from a technology standpoint, if fully autonomous robots become more integrated into the US market, I could see that with the precision of the cuts of bone really driving more of a cementless fixation boom, you can say.
Yeah.
From an evidence standpoint, I think, to Bob's point with some of the studies that they're doing, and I think that certainly as more people see that there really is no difference or no non-inferiority for that technique and long-term data comes out, I think that more people will migrate to cementless fixation.
Sure. Bob, your thoughts, what technologies or evidence will drive further adoption? Of course, some evidence is something you're working on right now.
Yeah. Yeah, I mean, from the tech side, Scott hit it. We're just going to get more accurate with the cuts, and that's one. I think a technique standpoint too. I think that we're going more in the way of personalized alignment. Whatever you want to call it. Kinematic, functional, inverse kinematic, whatever soup we're going to put together today, and that results in lower joint reactive forces. There's going to be a lower incidence of cementless knees coming loose early on due to overload of compartments. What we might run into trouble too with is if the bearings are too constrained early on. There's more of more constrained bearings coming out, and I don't know how that will work with cementless or not. Is that going to be a problem? Is it not going to be a problem? We'll see. Uh, but I just think techniques and more accurate techniques in terms of alignment philosophy, evidence we're putting out. So hopefully, people can do some peer review literature there, and then the robotics. That's it.
Sure. Charles, some comments on that?
Uh, I actually believe that there's probably going to be data that comes out eventually that establishes that cementless knees are better in some patients, just like 30 years ago or 25, it was established that in some patients with some bone, that a press fit femoral stem in a hip did better than a cemented stem. And I think there's going to be data that probably supports that there's a patient population that should be cemented in the knee, just like there's data that suggests that there's very limited small populations of hips that should be cemented. And I think as that data comes out, people will follow it. I think orthopedic surgeons, for the most part, are highly intelligent barbarians, and they will look at the data and they will follow the data along. I just don't think the data is quite there yet. But I really do believe there are some subsets of patients that will do better with press fit cementless knees than with cemented. And as we tease that out, I think you're going to see that adoption there for sure.
So before we go around the horn and sum up, I'm going to ask you guys to think a little bit what you want to say as your final comments. But in the meantime, I will use the moderator's discretion and comment a little bit on something Charles talked about earlier, which I thought was amazing about time in the OR and time waiting for cement. And people don't realize sometimes that OR time is 20 to 30 to $40 a minute. Most people say about $37 a minute, and saving 8 minutes per case, 6 cases a day, you may be able to get another case in. So the idea of something being only $600 more easily gets compensated by time in the OR if you could take advantage and put another case on or let your staff leave earlier or something like that. Just holding it, bringing it up for thought because cost was mentioned. And I think the cost now is with time being a cost, especially in a surgery center, a big deal. So I'd like to everyone to sum up. I'm going to do this in alphabetical order by last name. So we'll start with Scott. Some final comments for everybody.
Yeah, and just to double down on the comments I made earlier, I don't think cementless is for everyone, and I certainly don't want to encourage people that are against cementless knees to suddenly change their practice. But I do think if there is a curiosity there, if there is a desire to attempt the cementless knee, using good discretion in the patients that you choose, being very precise with your bony cuts and with your balance is very important. So do it the right way. I revise a lot of knees, both cemented and cementless, and I think that it's usually surgeon technique that's more of an error than the actual fixation with the current implants. And so that's really an important takeaway is, if you are going to make the switch, do it the right way.
Excellent. Excellent. Bob, some final comments for the crowd.
Yeah, I mean, it just cementless for all. I treat my knees like I treat my hips, right? I want my knees acting like my hips. I want the fixation to be as robust as my hips, and I'm going to do everything I can to give them that. So, um, yeah, we'll keep pushing on the evidence and the technology part, but give your patients what you think is right, and if that's a permanent implant, good on you.
All right. And Charles, you want to bring us home for tonight?
I don't have too much to add. Just again, I would just double down that choose your patients wisely if you're going to first start, switching techniques, just like anything, and pick the ones that are most likely to be successful early on to build your confidence. They're probably also a little more forgiving than the tweeners, if you will, or sort of pushing the envelope. And I've always said that I never want to be the first to adopt a technology, but I don't want to be the last either. And I think cementless knees currently falls in that range for pretty much every knee replacement surgeon. That they're certainly not going to be the first. There's tons of data on it now, and but that if they don't want to be the last, they might want to look for the right patients to give it a try with.
I'd like to thank everybody for tonight. This was a great session. I'd like to thank our panelists who were superb as always. And I'd like to thank all of you for coming tonight. And I'm going to say good night.